understand that occupational lung disorder is a very vast topic, but then spending too much of time on this topic may not be called for, because most of the MCQs that we have observed in the previous years are particularly targeted at certain pathophysiological findings or radiological findings. So we will make it a succinct MCQ kind of review. Okay. To start with the spectrum of occupational lung disorders, the spectrum is wide. On one end of the spectrum, we may have acute occupational lung disorders and we may have chronic occupational lung disorders. So if we divide them into acute and chronic, the acute occupational lung disorders include disorders like hypersensitivity pneumonitis. So HP in most of the settings is an occupational disorder. For example, Wool-Sorter's disease, or hypersensitivity pneumonitis that we see in farmers. Farmers, it is because of hypersensitivity to proteins of thermoactinomycetes, or other thing I can think of is hypersensitivity pneumonitis related to exposure to cotton, when we call it as bicyanosis, or exposure to sugarcane, where we call it as bagasosis. So these are all occupational acute lung disorders, right? Apart from this, exposure to beryllium can cause acute berylliosis, or exposure to certain metal fumes can cause metal fume fever. These are all acute lung conditions that are typically associated with occupational exposure. We are equally bothered about chronic lung disorders which are associated with occupation. And when I say chronic lung disorders, there are two possibilities. There are disorders which are occupation specific, like you are exposed to a particular substance in the occupation and that is why you are getting those disorders. Or these can be disorders where they are exacerbated because of the work conditions. For example, occupational asthma. So occupational asthma, you cannot pinpoint, okay, it is because of silica exposure or beryllium exposure, or you can't say, okay, an industry where a particular exposure is responsible for occupational asthma, but there are several such situations where asthma may be triggered, or in other words, sensitized by occupational exposure. So the sensitizer for asthma is present at your workplace. So when sensitizer is present at workplace, we call it as occupational asthma. So one end of the spectrum, we have non-specific entities like occupational asthma. And whenever I say occupational asthma, I mean the sensitizer for initiation of asthma is present at workplace. Okay. We also have a condition known as workplace exacerbated asthma. So in this case, the sensitizer is not present at the workplace. Basically, patient already has asthma, but these asthma are exacerbated at workplace. Typical example I can say is your workplace has hot, humid conditions. So you already have asthma. When you go to those hot, humid conditions, your airway is dried up. And if you remember in the asthma, we are discussing that dry airway is a triggering point for asthma. So you get a new episode of asthma precipitation. So that is what is workplace exacerbated asthma. So it is not initiated by workplace exposure. It is only exacerbated. But when we say occupational asthma, exposure to certain substances or chemicals at your workplace is the sensitizer that initiates the asthma. And you also remember a point that if you take the patient out from this workplace within 6 months of onset of asthma, you may be able to cure them of occupational asthma. But if the exposure continues beyond 6 months, even if you remove from the workplace, they may remain as asthmatic patients, though they will notice significant improvement, they will remain as asthmatic patients. So this is an important point, that if you identify that this is occupational asthma, if you take a proper history and be able to prove that the patient's asthma initiated once he started going to work, and you can link up certain exposures and asthma, and you take him off from the working place, you will be able to cure him of asthma. That was about occupational asthma. Similarly, you can have occupational COPD, especially where wood burning or coal burning is happening. A typical example, like females in India get COPD because of, I can say it is kind of occupational because cooking is their occupation, and burning wood is the primary source of exposure to smoke because they are not cigarette smokers. So that is also an example of non-specific chronic lung conditions associated with occupation. Coming to specific chronic lung conditions, few important we should be talking about. First one being coal workers pneumoconiosis. Okay, then we have chronic berylliosis. Then we have asbestosis and silicosis. These are important specific chronic lung disorders associated with occupation. Now, from the MCQ perspective, most of the questions in the past have been asked about these chronic specific occupational lung disorders, so we will be spending a little more time on them. To start with, asbestosis. The asbestosis is obviously because of exposure to asbestosis fibers. So, asbestos fibers are of 6 types, and certain fibers carry a high risk of developing lung disorders, and certain fibers have particularly low risk of lung disorders. So, one point I want you to remember, whenever we talk about asbestosis, this amphibole type of fibers, amphibole type of asbestos fibers are carrying the highest risk of causing lung injury. So, they carry the highest risk of creating all the trouble that asbestos creates. And obviously, those industries where asbestos is frequently used is associated with the occupational lung disorders. Okay. If you look at the epidemiology, most of the patients have a latency period of minimum 20 years, often ranging from 30 to 40 years before they start manifesting with manifestations. So, initial exposure, whenever it started, the latency period before you start noticing some symptoms of asbestosis is between 20 to 40 years. The least possible is 20 years. It can extend up to 40 years. During this period, again, the exposure of asbestosis becomes very significant because the manifestations are dose dependent. So, the more exposed you are, more likely to get the manifestations. And just like how we have pack years for smoking, here also we can have fiber years. So, these are called fiber years. So, how many duration or how many years you are exposed to asbestos fibers is what is known as fiber years. More the fiber years, more the manifestations. So, on an average, whenever asbestosis is diagnosed, most of the patients have more than 25 fiber years history from the point of exposure to point of diagnosis, at 25 fiber years of exposure to asbestosis. If you go a little more into details, you will find that when we are calculating fiber years, we are basically taking into account what kind of fibers they are exposed, because amphibole has a highest risk, chrysolite and certain other forms have a lower risk, and that is usually taken into account. But the point to remember here is that amphibole has the highest risk of causing lung injury. If you look at male to female ratio, then obviously, as expected, you will find that males are more affected. So, males are more affected than females, and this is simply because males are more likely to go and work in the places where asbestos exposure is happening, right? Those fields where construction is happening or mining is happening. Obviously, males are more likely to go and work in those industries, and thus the incidence is significantly high in males. Looking at the clinical manifestations, whenever I say asbestosis, I am particularly talking about asbestos-related interstitial lung disease, but that is not the only manifestation of asbestosis. Asbestos exposure can be associated with a benign entity known as pleural plaques. It can cause pleural plaques, which is a benign entity. This may or may not be associated with pleural effusion, but then it usually doesn't cause major problems. But this can also cause mesothelioma. Mesothelioma. This is a specific kind of pleural malignancy that we typically see in patients who are exposed to asbestosis. Mesothelioma does not only affect pleura, it can also affect peritoneum. So, peritoneal or pleural malignancy. This can also cause carcinoma of the lung. So, asbestos exposure carries higher risk of CA lung. Okay. And all these we call them as asbestosis related illnesses. Asbestosis related illnesses. But when it comes to asbestosis associated ILD, then we call it as asbestosis. Asbestosis. And if you look at the pathology, or if you do a biopsy of the patients who are having asbestosis, obviously pleural plaques and all are fine, they are benign entities. We are more concerned about asbestosis because that is an interstitial lung disease which relentlessly progresses, causes respiratory failure, and carries a significantly high risk of morbidity as well as mortality. If you do a biopsy, lung biopsy of these patients, you will notice that on their biopsy specimens, this asbestosis is associated with interstitial fibrosis, typically resembling usual interstitial fibrosis. So this point you have to remember, this looks like UIP type of ILD. So you remember from the ILD video, we classify into various types. So UIP is one, and in fact the common type. So UIP type of histopathological findings you will see on asbestosis or asbestos related ILD. What helps you to distinguish asbestos related ILD from other causes of UIP? That is a key question. So first point is obviously history of exposure to asbestosis. So history becomes very important, and if you miss this point on the history, then you will miss the diagnosis of asbestosis. So history is important, but apart from that, on the histopathology specimen, you will see something known as asbestos bodies. Something known as asbestos bodies. These asbestos bodies are also known as ferruginous asbestos bodies because these are asbestosis fibers which are loaded with iron-rich proteinaceous material. That is why they are also known as ferruginous asbestos bodies. So presence of this in the context of exposure to asbestosis plus ILD or UIP type of histopathological finding almost kind of confirms the diagnosis of asbestosis. If you look at the radiology imaging, on X-ray, most of the patients you may be able to see pleural plaques. Just because patient has pleural plaques, it does not mean that he should not have parenchymal involvement. Pleural plaques are very common, and their presence does not rule out the possibility of parenchymal involvement, and obviously you may be able to see telltale signs of parenchymal involvement in the form of reticular shadows. So you can see reticular shadows, but just like any other case of interstitial lung disease, chest X-ray is not a very sensitive test for diagnosis. When you do HRCT thorax, you will be able to identify these reticular shadows on the HRCT, and what becomes particularly important is distribution of these patterns, and you have to remember two words. First one is that these are usually basal, so basal portion of the lungs are more predominantly affected in asbestosis, and the second point is distribution is also subpleural. So these reticular shadows are distributed subpleurally and basally, and the upper zones are relatively spared. So point to remember: basal predominant and subpleural predominant, okay, and the upper zones are relatively spared. This is what you would see on a HRCT image. So if you look at this image, this is chest X-ray of a patient with asbestosis. So I'm not talking about pleural fibrosis, I'm talking about interstitial lung disease. You can clearly see those reticular shadows in the basal zone, and they are more on the subpleural areas. So you can clearly make that out, right? But if you look at a CT thorax, this is the same patient. On one, we are seeing the apical zones. So this is the higher section, and here you can clearly see that there is not much of involvement of the lung. But if you look at the second image, these are the basal zones, so you can clearly see subpleural. See, you can clearly see predominant subpleural involvement. Okay, predominant subpleural involvement in the form of reticular shadows. Obviously, often these conditions are associated with, just like we discussed in interstitial lung disease, there may be traction bronchiectasis. So you can see plenty of this traction bronchiectasis also. So point to remember, asbestosis affects basal more than upper zones, subpleural more than the other zones, and histopathologically it looks like UIP. One important distinguishing histopathological find is asbestosis bodies or something known as ferruginous asbestos bodies. This is exactly what or how a ferruginous asbestosis body looks like. So there is an underlying asbestos fiber layered with iron-rich proteinaceous material, and it looks like fragmented or segmented. It doesn't look like one straight line. You can clearly make out it looks like it is fragmented or segmented. The typical asbestos bodies, these are typical asbestos bodies. Okay, now let us move on to the Next image. So in this image, what you are seeing is again another asbestos bodies. You can see the segmentation. So these are segmented appearance. This is an X-ray of a patient with pleural asbestosis. So he has pleural plaques, but there are no parenchymal involvement, or at least on this X-ray we can't make out. So you can clearly see pleural thickening, right? You can clearly see these lines of pleural thickening, very, very typical of pleural asbestosis. Okay. So this is a case of pleural plaques. And you have to bear one point in mind. Sometimes these pleural plaques may be associated with pleural effusions. And you have to also bear in mind that on radiological imaging, we will not be able to differentiate mesothelioma or pleural cancers from benign pleural plaques. So for a definitive diagnosis of mesothelioma, we might need to do biopsy. And that is because the differentiation is difficult on radiological terms, and clinically we should be very vigilant. So someone who has asbestosis exposure, especially if there is more than 30 years history of exposure, and he comes with significant pointers towards a possible malignancy like weight loss or progressively worsening lung conditions, in that setting you should suspect a possibility of mesothelioma and subject him to biopsy for a definitive diagnosis. So that was about asbestosis. Now talking about silicosis, you all remember one word from your UG days, that silicosis is strongly associated with tuberculosis. For some reason, very frequently there is co-occurrence of tuberculosis in patients with silicosis. And we can also say that patients who are having tuberculosis infection may be more prone to develop manifest silicosis when they are working in particular occupational setting. Which occupations are at risk of silicosis? Well, wherever the sand blasting is happening or dealing with sand or silica or electronic industries, these are all occupations which are associated with silicosis. Just like how in asbestos we had different types of fibers, even we have different variants of silica. Silica is nothing but silicon dioxide, and we have various variants. Most commonly occurring, naturally occurring silica is quartz. And this is probably among the variants the safest one, because this is least likely to cause or initiate an inflammatory reaction when it is inhaled. But the other two, tridiamide and cristobalite, are significantly associated with high risk of silicosis. What are the manifestations of silicosis? Its manifestation typically resembles sarcoidosis with certain variations. So it can cause mediastinal lymphadenopathy, and very often these lymph nodes are calcified. So whenever you see these patients, you may see calcified lymph nodes, and typical description in the books is something known as eggshell calcification. So where you see eggshell calcification? You see eggshell calcification in patients with silicosis. I can show you, maybe if you can make out. So these are calcified lymph nodes, and the surrounding, they may have a clear calcified shell, maybe evident little more here. So they can have a calcified shell. Then we call it as eggshell calcification. Difference between asbestosis and silicosis is that this is a upper lobe predominant condition. So it is mainly affecting upper lobes. So it's a upper lobe predominant condition, unlike the patients with asbestosis where it is usually affecting the lower zones or lower lobes. On histopathology, what you see is this typically manifests in the form of small 1 to 2 millimeter nodules, which may slowly grow up to 1 centimeter nodules. These nodules, if continued exposure to silica happens, they will coalesce to form macules. These macules, when they are larger than 2 centimeter, we call them as nodules, right? So on one end of the spectrum, we have a simple silicosis where we see small macules, silica macules, but when they coalesce to form larger nodules, then we call the condition as progressive massive fibrosis. So progressive massive fibrosis is the most severe form of interstitial lung disease, where multiple nodules coalesce to form masses. Okay. So there are multiple small nodules which come together and form a mass. So there will be multiple masses formed. That is what we know as progressive massive fibrosis, and the prognosis of PMF is really very poor. Now what you are seeing in this X-ray is a typical reticular interstitial lung disease, predominantly affecting the, obviously I can't show whether it is an upper lobe slide or a lower lobe slice, but you can see the reticular pattern. Clearly you can see the reticular pattern of fibrosis. But what you are seeing in this image is, say this was basically a uncomplicated or a simple silicosis, right? Simple silicosis. But what you see in this image, you can clearly notice that those small nodules have coalesced to form large masses, right? So this is a HRCT image of a patient with silicosis having progressive massive fibrosis. Now there are two conditions which are prone to form or evolve into progressive massive fibrosis. The first one is silicosis and the second one is Kohl-Werker's pneumoconiosis. So the asbestosis was associated with UIP type of ILD. These two, when they progress, they lead to PMF. Now talking about Kohl-Werker's pneumoconiosis, this is typically seen in patients who are working in coal who are exposed to washed coal. And when I say washed coal, basically they have almost no exposure to silica. So even coal is a good source of silica, but if you are exposed to silica, then you go on to develop silicosis. But if you are exposed to coal, washed coal, where there is almost no exposure to silica, you develop Kohl-Werker's pneumoconiosis. This also in the extreme form leads to progressive massive fibrosis, but there are significant differences between silicosis and Kohl-Werker's pneumoconiosis. Just like silicosis, this condition is also associated with tuberculosis. So there are two conditions, occupational lung disorders, which are associated with tuberculosis. The first one is silicosis, like a very strong association, but equally significant association is with Kohl-Werker's pneumoconiosis. And Kohl-Werker's pneumoconiosis is also associated with increased risk of carcinoma of the lung. So there is a high risk of CA lung. This also we can divide into simple Kohl-Werker's pneumoconiosis and complex Kohl-Werker's pneumoconiosis. So when we say simple Kohl-Werker's pneumoconiosis, we have coal macules, which are nothing but, if you look at the histopathological imaging, you will see these coal macules, which on X-ray or on CT are looking as opacities, are basically regions of the lung where there are pigment-laden macrophages. Pigment-laden macrophages. What the pigment? Pigment is nothing but anthracoid pigment. So the coal pigment, we call them as anthracoid pigment. So anthracoid pigment laden macrophages are all clustered together, and that is what we call as coal macules. And they are usually less than 2 centimeters when we say simple Kohl-Werker's pneumoconiosis. Okay. This is a histopathological image of a patient with Kohl-Werker's pneumoconiosis, and this is a coal macule where you can see there are multiple macrophages which are loaded with anthracoid pigment. And when we say complicated Kohl-Werker's pneumoconiosis, we are basically talking about progressive massive fibrosis. So all these coal macules which were 2 centimeters in diameter, now they coalesce to form larger masses. So then we start calling it as progressive massive fibrosis. So point to remember about Kohl-Werker's pneumoconiosis is that this kind of resembles silicosis, with the difference that these patients are not exposed to silica dust, and otherwise on their imaging they may have a very similar presentation, and that has to be kept in mind. A particular point you should know is about coal macules. Now coming to the next important occupational lung disorder, that is berylliosis. Berylliosis is also known to cause acute manifestations, but then such cases are very minimal. Most of the berylliosis cases are because of chronic occupational lung disorder. And one interesting point related to berylliosis is that they have a strong association with HLA-DPB1. So you can see this HLA variant in 80 to 90% of the patients who develop chronic berylliosis. But its diagnostic utility is very limited because 40 to 50% of the patients, normal population also may have this HLA variant, HLA-DPB1. So the presence, though it is strongly associated, with berylliosis does not give us a diagnostic edge. We can't rely on it. Just like other forms of pneumoconiosis, even berylliosis is associated with significant latency period. So a minimum of 20 years latency is seen after initial exposure till the manifestations of symptoms start appearing. So this berylliosis also typically resembles sarcoidosis. This resembles sarcoidosis. So on presentation, these patients may be asymptomatic on one end of the spectrum, or they may have progressive cough and other respiratory manifestations suggestive of respiratory failure. Just like sarcoidosis, when you do imaging test, what you will find out is that these patients have mediastinal adenopathy, and they have granulomatous lung lesions, granulomatous parenchymal lesions. So on imaging, it will be very difficult to distinguish berylliosis from sarcoidosis. But if you take a proper occupational history and you demonstrate that these patients had exposure to beryllium, you may be able to substantially prove your diagnosis. Apart from that, you can do something known as beryllium lymphocyte proliferation test. What is this test? This is a test done to identify lymph nodes, lymphocytes which are sensitized by beryllium. So the lymphocytes which are sensitized by beryllium are identified by this test. So if you have a context where someone is having pneumoconiosis or a chronic lung condition which is resembling sarcoidosis, you have a radiological evidence supporting possibility of sarcoidosis, there is a history of beryllium exposure, and you confirm that these patients have beryllium sensitized lymphocytes, then your diagnosis of berylliosis is kind of confirmed, right? So these are the points you should know about occupational lung disorders. Before you close down, I have two more points that you should take home as important messages. The first one is that what would you see on PFT of these patients with pneumoconiosis? So on PFT, it is usually predominantly restrictive pattern. Predominantly you will see restrictive pattern on PFT. There may be some superadded obstructive component, but it is predominantly restrictive pattern. This is also frequently asked MCQ point. So they can ask you in cold workers pneumoconiosis, what kind of PFT finding you expect? You see restrictive type of PFT picture. And the second point I want you to take home is that something known as Kaplan syndrome, which you are all aware of, which is nothing but co-occurrence of three entities: rheumatoid arthritis, rheumatoid nodules, and pneumoconiosis in a single patient. So when a patient is having pneumoconiosis plus RA and rheumatoid nodules, then we call it as Kaplan syndrome. So they can ask you an MCQ asking which of the following is not a component of Kaplan syndrome. So you remember these three are components, and rest of the features of RA or pneumoconiosis are not the components of Kaplan syndrome, though they would be present with the patient.